I'm very pleased to introduce the next two speakers, Dr. Vincent Moore, Professor of Health Services, Policy and Practice, and the Florence Pierce Grant Professor of Community Health at Brown University School of Public Health, and Dr. Ken Ottenbacher, Senior Associate Dean for Graduate Education and Research at the School of Health Professions, and Professor and Director of the Division of Rehabilitation Science, Center for Recovery, Physical Activity, and Nutrition at University of Texas Medical Branch. Thank you.
Good morning. So I'm not a clinician, probably the only person in the room, or maybe one of the few people in the room, not trained as a clinician. I was fortunate, however, many years ago to be trained by public health nurses, social workers, and PTs who used to do interviews with little old ladies in Worcester, Massachusetts, not too far from here. And that's how I sort of learned before I learned how to do statistics. So the story I want to tell today is the power of uniform data in an industry. And so I'm going to sort of set this up. So how do these data ultimately go from the clinical application ultimately to the use in pragmatic trials as a vehicle and backbone? But then I'll have some final comments about sort of what are the limitations thereof. So I've got a bunch of co-authors and co-investigators for the work that we've been doing over the years, and funding agencies, mostly from the National Institutes on Aging. So the explosion of research in long-term care, specifically on the nursing home industry, has been made possible by uniform data. In 1963, the first National Nursing Home Survey was done. It was the first glimpse before Medicare and Medicaid started funding nursing homes, but we didn't really learn an awful lot. Then as CMS began the certification registration process, little by little, we get a glimpse of sort of who's where and what is the industry providing this kind of information. With the advent of the minimum data set for patient resident assessment, this actually made possible to actually characterize not just who's in the nursing home on any given day, but what's the stock and flow, who moves through, what do they look like, et cetera. The Nursing Home Resident Assessment Instrument minimum data set was mandated as part of the Omnibus Budget Reconciliation Act of 1987, which took effect in 1991. This was a vision of Sid Katz, who was on the Institute of Medicine and led the 1986 Institute of Medicine report looking at the quality of nursing home care. And his vision through all of this, having sort of been a geriatric physical rehab person, was that if you have uniform information and can structure the way in which the assessment process is done, you actually change the way that the clinician looks at things, and then ultimately, if you keep the data, you can actually use that exactly as it was described earlier this morning as a way to influence the way care is delivered. That was the vision, and then the MDS sort of is the pragmatic aspect of how it's actually done. There's an admission assessment, annual assessments, quarterly discharge, and since 2010, a discharge assessment as well. Since 1998, all MDS records are computerized and they're submitted to CMS on an ongoing basis. And as I said, there's a new version that came out in 2011, which actually asks the patients questions about things. So it's kind of totally unusual, and it's substantial. The content is demographics, physical and cognitive functioning, detailed manner, diagnostic information, mood, behavioral disturbances, pressure ulcers, pain, continence, what treatments are provided, what therapies and drugs are offered, and then what kind of professional care visits from physicians, et cetera, are given in the last 3 to 7 days. So it's a snapshot of what the patient looks like during their stay. So what are the implications? Pam used the term of a common language. Common definitions. So it's a common language for clinical explanations, common definitions for epidemiological health service research. It also it was the basis for the creation of case mix reimbursement, for better or for worse. With all of the perversion that goes with it, it's that common structure. It's also the basis for the creation of quality performance measures for regulators, consumers, purchasers, and providers. We're just really early on this long journey of how to use this information ultimately to inform the public and inform regulators and inform providers about their own performance. And there's lots of differences about how well some performance measures are working, but that's true for hospitals, for nursing homes, for home health agencies, et cetera. It also is really crucial in terms of understanding the changing composition of who's walking into these buildings, who's being treated there. There's been a huge transformation over the last decade and a half, and had we not had this information on everybody who walks in, we wouldn't see, other than the fact that there are now 2 million people a year who are moving through skilled nursing facilities, but most of the people who live there, it's like 800,000. So most of the bed days are for the long stay people. Most of the people move through quickly. And that's not an idea that people understand in the world of nursing homes as something that made sense until you actually see the data. So there are about 20 million plus records deposited every year, this massive database. There's longitudinal per person files that we've created, starting with the health insurance claim number, the patient's ID, linked to the minimum data set, and then linked to the entire sequence of all fee-for-service and Medicare Advantage patient records, creating a really substantial data structure. We've done a lot to match this to the Medicaid data through using the national MAX data from 2000 through 2012 now for certain people on the Medicaid side. The demographics make it possible, as I suggested, to match to the Medicare enrollment file, which tells you, are you dual eligible? Are you a Part D supplemental payment, which gets at information about income in a really, really important way. It's also linked to provider files so that we know a lot about the staffing level in each nursing home and so on and so forth. It's linked to area information so we know how many PTs per 1,000 there are in that county, how many nurses per 1,000, how many primary care docs, et cetera. And it's also linkable to Medicaid state policy information, which changes over time, creating lots of opportunities for sort of policy experimentation in the data source for that. The data are structured in a hierarchical manner. And so you start at the state. Can you? No, I have to actually. Is it this one? Nope. Yes. So we start at the state, and then within county, and then their facilities, and then their assessments, and their hospital claims and drug claims, and all of these are linkable hierarchically as well as longitudinally. So, first question is, are the data any good? So there have been lots of inter-rater reliability studies as part of research efforts, generally good comparisons of the data with research nurses when they're done, particularly the functional measures, which thank God are the easiest to get good and reliable on. There's good crosswalk with instruments that are measuring functional status and cognitive status that work well. Mood and behavior doesn't quite work as well. It tends to be depressed, even when you ask the patient or ostensibly ask the patient. MDS data, however, have a very strong prediction of hospitalization, of death, successful discharge. That is, the data are valid insofar as they behave that way. Can we actually say, will you go to the hospital next week? No, probably less well than we can do with real clinical data, but on average, people like you are not likely to go. So here's the mortality risk score, which we've constructed. The ROC curve is up over 0.8. It's really strong, and it actually works, not just for folks who are prevalent in the facility, but also at the time of admission, including mortality well after they've left the nursing home setting. Excuse me. We've got lots of information on the distribution of cognitive status. As of 2011, they actually now administer the cognitive status measure, and it actually performs very well in relation to what the prior assessment was, and about 80 7 to 95, depending on whether you're a new admission or a long stay, demented or not demented, people are able to respond to the actual questions being asked. And the construct validity of these measures are quite good, this cognitive function scale. And as you can see, there's a really big difference between the cognitive function of the cognitively intact for the admission cohort and the long stay cohort, where 17% are severely impaired. It's only 4% of those. Whereas other work we've been doing looking at delirium, which is a really nice measure embedded in the new measure. So it's really important, and this has a profound effect on your functional gain over a 2-week period. This is more information on this cognitive function scale, and in terms of its ability to actually show the relationship between total dressing, and you can see this huge difference in the function associated with the clinical status. We also measured discharges for years. We said we had to rely on the Medicare claims data to see what happened to you. Now the correspondence between a discharge record from the nursing home setting to a rehospitalization measure, that is the new admission of on a Medicare claim, is very good. And this makes it possible for us to use, we get the data every quarter from CMS. Every quarter we can generate for every nursing home in the country a 30-day rehospitalization from nursing home. Not from home if you've gone home on day 20, but from nursing home. And this has dropped dramatically over the past years, and it's now under, it's about 17%. We also can use it to create aggregate measures to formulate something that people care about, going home and staying there. So we've created something called a successful discharge record, which is basically saying you got out and you stayed out for at least 30 days at home without going directly to hospital and without coming back to a nursing home, because we have all of the data so we know if they've ever come back to any nursing home. And there's huge variation in the probability in the state level rates of these average successful discharge rates. And so I don't know where North Carolina is, Pam, but it's someplace in here. Then we also have the change in ADL self-performance between admission and discharge. And again, this is with the new measure. And we're looking at people, full sample, discharge home, hip fracture, and we can see that there's this sort of classic third. The percent improved with the hip fracture is about 70% of the hip fracture admissions. And so you can measure that, and it's within a 2-week to 3-week period from admission. The data are also extremely useful for doing really classic pharmacoepidemiology to understand what the effect of an exposure to particular kinds of drugs are on outcomes, be they hospitalization, morbidity events, mortality, but also functional change and decline. The drug exposures matched to Part D are really terrific. They're very solid in terms of the ability. And unlike pharmacoepi with just claims data, which is the ability to measure function and cognition at the same time is really quite profound. So we just finished a study looking at beta blocker use in very sick old people who are resident of nursing homes having an MI, and whether or not they come back to the nursing home with or without a beta blocker. And without a beta blocker, you find people have higher mortality rate, just like the randomized trials of beta blockers, even up to the age 75. This is the sickest population studied. And so what we also see is, however, that there's an increase in functional decline for the people who actually survive, introducing this interesting clinical trade-off. And further work we've looked at is that is a trade-off only in the most severely functionally impaired, so that the advantage of the beta blocker with respect to mortality persists regardless of function, but the trade-off is most obvious with function is most obvious in the sickest patients. So it introduces a really good mechanism for actually informing geriatricians on that prescription side. This is just some information on that. We've also created an aggregated data source. You can go to ltcfocus.org, and I was at the Academy Health meeting the other day, and it's just so amazing to actually see people writing their dissertations using data we put up on the web, which is all de-identified, it's all aggregated, and it's available to help study the industry and the distribution of patients in the industry. And this is what it looks like. But perhaps the most exciting and interesting thing is that this is now a platform for doing phase 5, cluster randomized trials. Provides a uniform, consistent data flow on 4 million patients per year. The link to Medicare enrollment and means that there's no loss of data. The existing data makes it possible to reach out and precisely recruit a subset of facilities with the characteristics of the patients you want in your study a priori. You could also make repeated assessments of the individual so you can actually measure outcomes other than mortality and rehospitalization. And it actually can be embedded in lots of other ways. So we've just finished a large-scale cluster randomized trial of high-dose influenza vaccine versus standard dose influenza vaccine in the nursing home setting. We used the minimum data set, aggregated information to identify facilities that had a minimum number of patients who were long stay, which is perfectly possible to do, that were close to one of the 122 cities in which the CDC monitors flu severity on an annual basis, in fact, weekly basis, making it possible. So here are the participating nursing homes with 800, we recruited 823 nursing homes, randomly assigned half to get high dose and half to get standard dose. In a very elaborate way in which we identified which facilities made it and who could do what, because we knew a lot about them in advance. It ended up with random assignment work. We had very similar groups, classification of patients across the nursing homes in the 4 groups. It was a 2-by-2 design with free staff vaccine as well. And then within the patient population, we have all of the data, which means that we can then say, a priori, I'm only going to study this class of patients. We wrote it up in the protocol, so we couldn't, quote unquote, cheat post hoc, even though we had all the data. And then you can actually look at what the effect is on that subset population over the period of the flu season that we looked at in 2013 and 2014. Again, the balance was quite good across the 2 groups, between the experimentals, the high dose and the standard dose groups. And it really made it much easier to be able to look at the overall analyses. Censoring in this study was balanced, so we had, of the 21,000 individuals per arm for the high dose, standard dose, 4,600 basically died during the study period, about 17%. A few were in the hospital during that end of the time period, so we didn't know exactly where they were, but that was at the close of the hospitalization period. So we could actually document in very great detail without ever seeing a patient. We looked at seasonal index hospitalizations by month for the high dose, low dose, and virtually in every single month, the standard dose group had somewhat more all-cause hospitalizations. We've just finished all of the other analyses. In addition to having a 1% reduction in all-cause hospitalizations for the in the high-dose group, the relative reduction in hospitalizations amongst those hospitalized with respiratory conditions was about 20% for the people who were Medicare fee-for-service. So that is how we can do a trial. It's much easier to do that kind of drug trial. Everybody in home A gets the high dose, everybody in home B gets the standard dose. It's not like trying to do the COMPASS, which Pam talked to you about. But we're now doing a large cluster randomized trial of pragmatic video education in the nursing home setting. It's basically video-assisted advanced care planning, and here we're working with 2 large nursing home chain partners. And again, we can identify from the 2 large partners those facilities that meet our criteria that we needed to have in the group, both with respect to the characteristics of the facility in terms of their total throughput, but also in terms of the characteristics of the patient population. And so we were able to then go through and identify the facilities that get randomly assigned to experimental and control. And so we end up with 120 experimentals, 119 to be exact. And because there's no added cost of having additional controls, We have 240 controls in the process, facilities. We can also identify target subgroups. So this is a pragmatic trial, so everybody who enters every one of the 119 experimental nursing homes is offered the opportunity of seeing one of 5 videos about an advanced care planning issue. Those videos are offered at the time of quarterly or semi-annual patient care planning meetings with patients and families during the course of these quarterly care planning meetings. And then, even though everybody's exposed to the intervention, our primary outcome is focused on only those people who have the highest risk of a hospitalization that might not be necessary or beneficial because they're very sick, very demented, have very bad COPD or CHF, and therefore a hospitalization might not actually help them, it could actually hurt them. And so that's the outcome group for our primary outcome, although we're testing the effect of everybody else on the secondary outcome. So like Pam, we're in the midst of actually doing this right now, and we are actually watching every 2 weeks as reports come back in with how many people are offered, how many people actually accept seeing the video, which video is being seen, whether family members are watching it. That's the only new piece like Tony, that's the only new piece of information we put into the system. Otherwise, it relies entirely on existing data sources. So we're actually integrating these data as we get it from our partners, and then these data are being exported, uploaded onto the CMS Virtual Research Data Center. We're one of the first people using this to actually track outcomes from claims on a more rapid basis. Instead of waiting 2 years for claims, you actually get to watch them as they come in. This makes it possible to do interim analyses for our Data Safety Monitoring Board as we're looking through it. So the availability of detailed, uniform, longitudinal, person-level data opens the way to lots and lots of different things for providers, for policymakers, for regulators, and obviously for researchers as we sit back and catch the data as they come out. It's great for aggregating performance measures. It's really great for observational data analyses. But the most powerful thing is what we're actually discovering now. It's real-time data tracking using a cluster randomized trial is truly revolutionary, and now that's what we're doing. I've been doing observational studies for 30 years, and now I'm doing these large-scale trials to try to make a difference, to take what's known out there to actually make a difference in the way care is delivered for both long-stay as well as short-stay patients. But just one final comment, as you know, while these data create tremendous opportunities for quality measurement, to compare providers across performance measures, it's kind of sad to say that the power of the data are probably underused by the industry, underused by the clinical community that could be using them, because only some providers are using these data for risk stratification, for triaging who should be getting what kind of care, to actually use them to inform care at the bedside as we move forward, even though the data are now, every nursing home in America has a complete EMR that could actually generate this if there were the demand and ability. And therefore data is really not enough. You must have the right collaboration with people who know how to ask the questions of the data to inform practice at the same time. And the thing that's so exciting, I'm not a PT, the thing that's so exciting about getting involved with actual clinicians embedded in healthcare systems to do this kind of work is that some of you will learn how to ask a question of this kind of big data to make a difference in clinical practice as it happens in the delivery system. Because otherwise, we're just collecting data for fun. So thank you very much.
Well, good morning, or I guess I guess I should say good afternoon, everyone. So I'd like to also acknowledge the CoStar leadership, and particularly Dr. Resnick, for the opportunity to be here today. I really do. I've enjoyed the presentations, and I'm learning a lot. I'd also specifically like to thank Mary Slavin. So Dr. Slavin just did a wonderful job in terms of organizing this. It's been a pleasure. So let's go ahead and get started. So as a speaker, I was sent these questions. I'm not going to read them all, but these are the questions that I was sent to respond to. I'm assuming that all the speakers were sent these, but I'm not quite sure. But I looked at these, and kind of based on these questions, I came up with an outline. And so my outline is here. And I'm going to talk a little bit, my presentation is going to be a little bit different than the previous ones. We've had some just fabulous presentations this morning about the applications of health services methodology and about the ongoing studies, the pragmatic trials, and certainly Vince just talking about the health services research opportunities available in the Medicare data. But I think one of the functions, one of the missions, and again, I'm not part officially of CoStar, but I think one of the missions of it, although I have to admit, my clinical background is occupational therapy, and I'm very jealous. I'm very jealous that you all have the commitment from your professional organizations to invest in health service research and to invest in the research capacity building of the profession, to take advantage of the opportunities that are inherent in a lot of things that we've heard about today and things that we haven't heard about, that we don't even know about, that are going to be coming down the pike as healthcare continues to change. So I'm going to talk a little bit about, again, one of the missions I think of CoStar is to build research capacity. Vince was just talking about the opportunities available in using the Medicare data and the nursing home data, the MDS. But those opportunities don't get taken advantage of unless you have people who have the background and skills to do it. So I think one of the goals of CoStar is to build research capacity and the infrastructure for people to engage in health service research and to do these kinds of studies, these large data studies. Vince mentioned Academy Health. So how many of you know what Academy Health is? Okay, fair number. How many people were at there was an Academy Health meeting just here in Boston right before this meeting? How many people were at? So a few. Okay, good. So what we need is to have more clinicians who go to Academy Health. And they go to Academy Health and they present, and they learn, they meet people like Vince and other health services investigators who can collaborate with them and use the data that Vince was just talking about to answer the questions that are important to rehabilitation and to physical therapy. So I'm just going to spend a little bit of time going through each one of these. So this first one, this models, each of these were a model, we're model 4. So my interest in this, most clinicians, and I'm sure for most of you, and I've probably been around doing this longer than most of you, but when I went through my graduate training, the graduate research and the statistics and this kind of scholarship that I learned to do in terms of research was patient-oriented clinical research. That's the kind of research I learned how to do. And that's the way it should be. We're clinical fields. That's what we should learn how to do. But there's real opportunities in these large data sets and in the health services area. So I started out with just like most of you, I became an OT because I was interested in helping people. Somebody made a comment about that earlier. And I became a clinician. I worked in the clinic for a while, and I wanted to know how you can improve therapy. How can you do things better? And so I ended up having the opportunity to be in an academic institution. It was primarily a teaching institution, but I really liked that experience. And I developed some research interest in research as a result of that. And I got particularly interested in measuring function. And I was very fortunate I spent 10 years at the University of Wisconsin in Madison, and then I spent about 6 years at the State University of New York at Buffalo. And when I was at Buffalo, I worked with the folks at UDSMR, the Uniform Data System for Medical Rehabilitation, and Carl Granger and Byron Hamilton and the folks that were involved in developing the FIM. And And they had what at the time I thought was a really large data set, because they were collecting data on the FIM from a lot of inpatient rehab facilities. And that was a wonderful opportunity for me to start this transition from the more typical clinical research that I had been doing to this large data type of research, which I hadn't really done, but it was really interesting. I was interested in function. And so I kind of learned how to do it. And I learned how to do it the hard way. Now there are courses and there are meetings like this and there are opportunities to do that. And that's what we need to do, is we need to continue to develop that. For those of you who might be interested in know Dr. Granger is now approaching 90. And he's still well, healthy. He comes into the office 2 or 3 times a week and works on his little projects. And so he's doing well. I'm going to see him in a couple of weeks. So that led to the large data experience, the interest in large data. So we've been doing large data research for ever since I've been in Texas, which is now almost 20 years, a little over 20 years actually. And most of my time now is spent developing infrastructure. I see that as my role. My role is to help develop infrastructure, and we do a lot of mentoring. So I want to talk a little bit about that, and again, this research capacity building and how we've done it, to have you start, because you all as a field need to, and we all, I'm including myself, as somebody who's interested in large data and health service research, regardless of our discipline, we need to have the infrastructure to train people to do this kind of work within the rehabilitation community. So this kind of goes to my philosophy about research capacity and research in general. So Lewis Thomas, some of you may know Lewis Thomas. Lewis Thomas was a physician. He was the director of Sloan Kettering Cancer Institute for a number of years. And he used to write essays when they had essays in the New England Journal. And his essays were occasionally published as books. And so this is a quote from one of Lewis Thomas' books, and I'm just going to read it. Science is instinctive behavior, in my view. I do not understand how it works. It cannot be prearranged in any precise way. The minds cannot be lined up in tidy rows and given directions from printed sheets. You cannot get it done by instructing each mind to make this or that piece for central committees to fit with the pieces made by other instructed minds. It does not work this way. What it needs is for the air to be made right. If you want a bee to make honey, you do not issue protocols on solar navigation or carbohydrate chemistry. You put him together with other bees, and you better do this quickly, for solitary bees do not stay alive. And you do what you can to arrange the general environment around the hive. If the air is right, the science will come in its own season, like pure honey. And I believe that. That's been my philosophy in terms of how I've done research and how we've tried to build research programs. And the question is, the challenge is, how do you make the air right? How do you create an environment where people can be successful and enjoy what they're doing? Because it's really, really hard to do this. To be a successful academic in a research environment these days is really difficult. It's the funding levels, all of the things that you have to deal with. So you have to want to do it. You have to be motivated to do it. So to make the air right, you work in the right setting, you hire the right people, you provide the right resources, and you offer the right incentives. Those all seem like fairly straightforward things. You can say they're simple. And a lot of times people equate something that's simple with something that's easy. If I want to lose weight, what do I have to do? I just don't eat as many calories. Sounds simple, but it's not easy. And this isn't easy either. But making the air right is what we all want to try to do. That's what you need to do to build research capacity. So this is our model, I'm talking about we're Model 4. We have a division of rehabilitation science at the University of Texas Medical Branch. And I know you can't read this, but this reflects, and we created the division when we created our PhD program in rehabilitation science. And large data research it's population-based health service research is one of the areas, but we have 4 areas that we focus on. And that's good because you want to have the interaction with people who have different interests and come from different backgrounds. Our division is interdisciplinary. It's not just PTs or OTs, or it's not even just rehab people. We have a bunch of infrastructure grants that are here, and I'll talk a little bit about those later. And then the collaborations, these are internal collaborations, and these are some of the external collaborations. So that's, in a broad sense, our model. So one of the other, from the questions, one of the other outline topics that I identified was context and infrastructure. So you have to understand the context of your institution in terms of building infrastructure for building research capacity. So I'm at the University of Texas Medical Branch, and we're an academic health science center. We're not a real university, even though university is in our name. We're a freestanding academic health science center. So we're very much a medically dominated healthcare providing facility, and we're run much more like a business or a hospital than we are like a university in a lot of ways. There's no English department, there's no psychology department, there's no music department, there's no engineering department, but it tends to be a fairly collegial place. And I tell people, we don't have a football team. How can you be a university in Texas and not have a football team? So you have to, one of the questions on the list that I showed a minute ago was what motivates your institution? So that's actually an important thing to understand. What are your institution's priorities? What are they going to support? So this context. So our PhD program, this is how our PhD program is set up. And I just am giving this as an example, and then when we have the questions, we can talk a little bit more about it. So we have a rehabilitation sciences PhD program. It's interdisciplinary. We just recently were accredited by the Council on Education for Public Health. I think we're probably the only rehab sciences PhD program in the country that's accredited by the Council on Education for Public Health. Our PhD program is clustered, is part of a cluster of PhD programs at our university. There's a PhD program in rehab science, one in population health science, one in clinical science, there's an MPH, and there's a master's degree in epidemiology and biostatistics that's going to become a PhD program soon. And the university views that cluster, we share a lot of courses, we share faculty, there's a lot of interaction between the students in those programs, and that works really well for us. That's a nice setting to be in terms of the health services focus. Now, we have collaborations with a lot of other groups, and as I showed you a minute ago on the model side, we have folks that are doing work in aging and some other areas of muscle physiology and muscle biology. And we have a Pepper Center grant. And so those folks all fit in there as well. But they may do their PhD stuff in a slightly different area. So we have collaborations. It's important to have the collaborations, both internal collaborations and external collaborations. The external collaborations that I'm listing here, these consortium collaborators over the last 5 years, these are fairly major collaborations. We have contracts with each of these folks through grants that are at least $100,000 or more. So they're not just single subcontracts to a grant. But that's part of the infrastructure, is having the connections, having the feedback, getting the experience and the ideas that come from different places. So as I said a minute ago, I see my role as helping to build infrastructure. So it's important to have those infrastructure kinds of grants. And some of those that we have are listed there. And this is kind of the pipeline that's related to that infrastructure. So we've set up a system where we have the predoctoral training program, which is the PhD in rehabilitation science. And we have a postdoctoral program, just postdoctoral fellowships. And then we have a career development awards, the early career development program. And all of those have, they're funded by, they're part of the infrastructure grants. So we've been fortunate to have funding to keep various parts of that pipeline going fairly consistently for the last 20 years. We don't have the T32. We had T32 for about 11 or 12 years. We don't have it right now. It was really, really important in the early days. We wouldn't have got the PhD program without that. But now we're to the point where we have enough other kind of funding that we don't really need the PhD program or the T32 program to keep the PhD program going. We've got other funding to do that. And the graduate school now is giving us for the first 10 years, we didn't get any money at all from the graduate school. And I didn't want money from the graduate school because if they give you money, then they expect you to do things. And, now we're getting some of the stipends from the graduate school because they don't have enough basic science people to give their stipends to. So we're getting some of those. So and that's been great. But it's just the idea of having that pipeline and thinking about that trajectory in terms of training people and building that, building the research capacity. And that's part of the infrastructure. So the third, I think the third bullet I had on there was opportunities and resources. This is really a great time to be in the health services area and to be doing the kind of work that, that Dr. Moore was talking about. You know, the Healthcare Reform Act, I think, is here to stay, no matter what happens in the political environment. I think there have been so many changes to the health system, they're not going to go away. The health systems have changed and hospitals have changed how they do things. And even if the Affordable Care Act were repealed tomorrow, it's not going to go back to the way it was. It just can't. So there really are a lot of opportunities that didn't exist 5 to 10 years ago. And those include things like the Affordable Care Act. All of the work that's been going on related to value-based purchasing and quality indicators and quality outcomes that you've heard people talk about, you know, that's now part of the system. And it's a great fit for us because that's what we want to do. We want to measure outcomes. The PCORI, you heard about 2 very impressive PCORI studies and programs that are being led by physical therapists. So that's another huge opportunity for us. This is a article that was in the Brookings Institute on their webpage a while ago, a couple of years ago, about the emerging revolution in healthcare, and that it's going to change service delivery models, it's going to change reimbursement, it's going to change quality metrics, and it's going to change patient outcomes. And we're seeing that. And in the Affordable Care Act, a lot of the press about the Affordable Care Act in the first couple, 3 years after it was passed in 2010, was about getting more people signed up for insurance. And you hear about it from kind of the acute care end. But the things that are happening now are very much more focused on the post-acute care world. And they're going to change the post-acute care. The post-acute care world is going through massive changes. It's very clear that fee-for-service is going to go away. And fee-for-service drives payment for all those folks that are in Medicare. And for those of you who know Gerben de Jong, who's a health policy person within the rehab world, Gerben is fond of saying, payment drives practice. When the payment system changes, changes in practice will follow. So we're interested in quality metrics and patient outcomes. We try to connect our research to legislation. So a big piece of legislation that's having a major impact is the IMPACT Act, Improving Medicare Post-Acute Care Transformation Act. That's, if you don't know about the IMPACT, everybody know about the IMPACT Act? So the IMPACT Act is going to require standardized function across all the post-acute care settings. So post-acute care is going to change. We also, we do a lot of work with Medicare data, but we're also interested in linking Medicare data and using other kinds of data sets. And these are just a couple examples here. So these are examples of some of the data sets. There's just an amazing number of data sets that are out there. A lot of them public use data sets, data that's been collected by the federal government in a variety of different ways. These are all data sets that have been used by our graduate students or our faculty in the last probably 5 years or so. So they don't all just use Medicare data. In fact, most of our graduate students now are not using Medicare data. So resources, that was the last bullet. I want to just go through this quickly. So this is resources for large data. So we have a Center for Large Data Research and Data Sharing, and it's an NIH-funded center, and it's a service center. It's designed to provide services to you, to the field. And we have an evaluation and training component, a data directory, pilot projects, visiting scholars, and a data archiving service. So this is our data directory. If you want to find out information about data sets that we think might be, and it's not just we've surveyed the field, we've got feedback, might be of interest. You're interested in doing a particular study and you want to know what's out there. Is there a data set that has that variable on it? You could go to our data directory, and I think we have about 60 data sets in there, and there's fairly detailed information about the data sets. We have a pilot project program. We have a visiting scholars program. We have two different types of pilot projects. The pilot projects are up to $25,000 to help people get started doing large data work. We have a visiting scholars program for people to come and, if they want to learn something about how to work with data sets, how to manage data sets, we have that available. We have a data sharing. This is new. This is part of the archiving requirement that's now people are hearing about, the data sharing process. So this is a new thing that we've added in the new cycle of the grant. So there are resources out there for you as rehabilitation-related investigators who are interested in learning about large data sets. A lot of times when I'm thinking about this, I'm reminding of these lines from T.S. Eliot. This is the poem, The Rock. And I left off the first part of them. Where is the life we have lost in living? Where is the wisdom we have lost in knowledge? Where is the knowledge we have lost in information? And with apologies to Eliot, where is the information we've lost in data? Because, you know, in 2012, NIH came out with a BD2K, the big data to knowledge. Well, yeah, we might be getting towards the knowledge area, but we aren't to the wisdom area yet. The big data, the BD2K is a wonderful, it really increased the visibility for large data sets. So everybody, when we first had our first cycle of our infrastructure grant in 2010, I had to go around to kind of beat the bushes to raise awareness, to get people to say, why would you want to do that? You know, I'd go to places and talk to folks and go to conferences and go to university, probably went to some of your universities, just trying to drum up business for our center. And then in 2012, the BD2K hit, and boy, there was a data explosion. Everybody's interested in big data. There's money, there's funding, so we don't have to raise awareness about that anymore. So talking about the centers, this isn't related to health service specifically. This is just a resource for you as physical therapists and as rehabilitation practitioners. NIH funds 6 of these resource centers, and they're on a wide variety of topics. They all have similar activities that we do. They have an education and training program. They have pilot studies. They have a visiting scholars program. You probably can't read this, but the slides are available, and you should have a copy of these. So if you're doing research in an area, or you know someone who's doing research in an area, these are wonderful centers to help you be successful in developing your research. And again, they're service centers. So I'm going to end with another quote. This is, I really like Joseph Campbell. Joseph Campbell, for those of you who don't, and Joseph Campbell has written widely about the role of myth and legend and culture. He's just a wonderful author. And this is from one, he's the one that Follow Your Bliss, that he's the one who wrote that and kind of that's coined that term. We can only have those adventures in life that we are ready for. Well, the profession of physical therapy is ready for the adventure of health services research, and I certainly congratulate you on that and hope you take full advantage of it. And this is information related to our center and the contact, and I'll stop there, and I guess we'll see if there are questions and comments, and then we'll have lunch. So thank you all.
Okay, we have time for a few questions. If you want to raise your hand, and the mic will come to you. In the front row.
Wonderful presentations. You both have mentioned the whole idea of translating data into information, into knowledge, into wisdom, which I don't know how many DIKW fans there are in the room, but this is kind of the foundation of informatics, and it takes me back to how do we, and Dr. Moore said, people don't know how to use data. And then you have to know how to ask a question of that data to get information, how to put that into your local context to have knowledge, and then to make proactive changes to have wisdom. So back to the IOM report on the competencies that we all need to have in terms of informatics. How do we integrate informatics, which is one of the things we're struggling with at UNMC, into our physical therapy curriculum? Because the bachelor's prepared nurse, the DPT prepared physical therapist, how do we teach people to use data to change systems? Because it's not easy.
Yeah, personally, that's a great question. Because I didn't understand a lot about implementation, how difficult it is to change behavior, when the MDS was created and then computerized, I said, around the corner, people will be, I can imagine somebody managing a nursing home with 4 data screens up there, just like you're doing your investment portfolio. Not really. And so I don't have a good model for how that goes. I just know there need to be more people with different levels of exposure to different understandings of the power of that data, whether it starts in initial clinical training and then filters on with greater and greater exposure over time. I'm not sure. I just know how we train PhD students, and even my PhD students take another 5 or 10 years after they've worked with the data to know how to properly speak with somebody from the clinical world and how to properly speak with somebody who's actually implementing a program in the field to help them think about the utility of this kind of information. And I'm as guilty as everybody. I work with a number of nursing home companies, and my first exposure is always, you could do this, and I forget that you can only do one thing at a time well, often. And you have to build on that. But it's expectations.
Yeah, I mean, it's clearly a challenge, but a lot of this is relatively new to us in rehabilitation. So that's exactly why I think we need to have programs like CoStar, because that's the place where those things should, I would think, be incubated. So how do you, I would think that would be a question that the CoStar folks might want to grapple with. There's the whole emerging area of data science, which, using data to drive discovery. Well, you could always say we've used data to drive discovery, but it has a different context now because there's just so much data. There's just so much information out there. So I know universities, we're talking at our place about creating an institute of data science, because universities are starting degree programs in data science, PhD programs in data science, and related to the whole implementation side. So we're in the pretty early stages of this, and you think back, whether you may or may not be a fan of evidence-based practice, but you think back when the evidence-based practice movement really started. In the early 1990s, the 1992 is the article in JAMA on the first time where they really used the term evidence-based, was evidence-based medicine back then, but and look how that has evolved. And now, for the first 5 years after that, if you would have asked clinicians what are they doing evidence-based medicine or evidence-based practice, they probably would have said, what's that? It didn't mean that much to them. But now everybody knows what evidence-based practice is. It's taught in curriculums and it's integrated. Now there are arguments about how well it's integrated and how well it works and all of that, but it's something that's just going to take time and not just time, but people paying attention to it. So that's why things like CoStar, I think, are so important. You've got a group of people who have a very specific agenda in terms of what they would like to see happen with physical therapy. And then how then do you integrate that? Do you integrate the expertise from data science and implementation science and the bioinformatics into that? I mean, I'm not sure where you're at, but if you're at a place that has a CTSA, I'd be talking to those folks, because most of the CTSAs have some kind of institute, and usually the bioinformatics is a fairly big part of that. And their mandate is to integrate that, is to help it to use informatics to help translation, right? That's what those institutes are all about. So it's making those connections and collaborations and then just thinking about, well, how do we do this? How do we put this into the curriculum? Do we teach a course about it? What makes the most sense? But I don't know the answer either. But it's an important question that we should be struggling with.
Okay, we have time for another question. I think you were next in second row.
Hi, Dr. Ottenbacher. I was just wondering, given your experience being a mentor of multiple K awardees, what you think of in terms of a K mechanism for the profession of PT and OT. I think it's more common in the PT profession to have a PhD and then apply for a K, but given your experience with patient-oriented research, where you're, that's kind of my main interest, working with clinical research in prospective trials. So I think I just wanted to hear your thoughts in terms of a K mechanism in terms of receiving research training.
Well, how to answer that? So we have a K-12 grant that's an institutional K award, and it's specifically for physical and occupational therapists. And there's two of those awards, the court K-12 grant, which I'm sure most of you are already familiar with. And the K-12 mechanism, the grants that we have are really wonderful infrastructure grants for, again, early career development. And the nice thing about the institutional awards is that you apply to the institution for the K-12 rather than applying directly to NIH. So, and we get people, we had one of our folks who is a PT, she's not here, but she's at Academy Health, who did a postdoc, applied for our K-12, and she's doing large data research, and that's one mechanism. Or there's the more direct NIH approach, which is the K-01. And the K-01 is probably the most popular. There's the K-23, and there are other K mechanisms as well. Most of the people that I've worked with have been K-01s. We've had a couple of people who have had K-08s, but most of them have been K-01s. One of the nice things about rehab, and again, many of you probably already know this, but NCMMR, the K awards at NCMMR are reviewed within the function integration study section. That's an institute study section. And they actually give priority to people who have clinical backgrounds. So if you apply to the K award through NCMMR, you're likely to get people on the study section who know what rehab is and who understand it and maybe a little friendlier than some of the other study sections that are very large and may not know that. But it really depends on what if your research interests are in a specific area, then it may make sense to do that. And it's just finding out what things they've funded before, what kind of, again, through with the reporter now, you can go on, you can find out all kinds of things about grants that have been funded by different institutes and who's gotten K awards in different areas, and you can see their grant, we can see their abstracts. So it's worth doing some homework on that. And to get a K award, you really have to be part of a team. And you have to have mentored, the mentored K award. So you have to have a team, and you have to have people that whoever your mentor is should have enough of a background and experience to help you make those decisions about where the best fit for your particular K award is going to be.
Okay.
K awards are they're a wonderful resource, and we really try to get people to do K awards because it gives them protected time, which is a very valuable thing, particularly for people in this field when they're first starting out in their careers.
Thank you.